Good afternoon. I'd like to call today's joint hearing to order. We've already blown the lights out, Ms. Yamada.
Our job is to keep the lights on.
That's right.
Right.
Thank you very much for joining us. Today's hearing will be on the long-term care integration and Medi-Cal managed care. The title of the hearing is The Future for Beneficiaries, the Workforce, and Our Health Care System. Let me start today by providing a little clarification to all in attendance today as to the role and function of today's joint hearing. The administration's proposed budget contains numerous policy and programmatic changes which can have direct impact on millions of Californians most vulnerable. As a result, the legislature has a fundamental responsibility to do the following: to understand and even better have a working knowledge of the current structure and functions of the programs and services that are in question. Secondly, to learn about the budget proposal via testimony from the administration as well as reactions to it from the LAO and other key stakeholders. Third, as a legislature, we have oversight responsibility over these state programs and departments that run them. And finally, we have a responsibility to take all the information presented and make a decision about what we collectively feel is in the best interest of California. So in order to facilitate that learning and thoughtful deliberation, we have fashioned a robust agenda, created an opportunity for us to hear from all of you who are in the know. That includes advocates, beneficiaries, the administration, the LAO, stakeholders, and our constituents, the general public. So to review today's agenda, I previously stated that it's quite robust. We're going to ask all of the witnesses who are here to testify to really stick closely, if you will, to the time restrictions that I've outlined. I have every confidence that you'll be able to get your point across and express your concern or your interest in these issue areas within the stated time frames. My goal today, colleagues, will be to run a hearing that lasts about 4 hours to get us out of here by 5:30. You'll also note in our adjustment of the agenda that we have public comment earlier in the agenda as well as in the evening. I fully understand, and I think it's unfortunate that many times we fashion our agenda where we take public comment at the end and we expect you to stick here until the late hours. And so it's our effort to try to accommodate travel schedules and family obligations and child care obligations. So midway through the agenda, we'll take about 20 to 30 minutes of public testimony. I will ask really that you kind of self-police. If you can be here to the end, I ask that you do that and accommodate your fellow Californians who may have travel restrictions and need to get on planes and leave here early. So I will, again, we'll time limit it to about 20 or 30 minutes, and as the people line up, I may cut the line off just based on time. But again, it's our effort to really incorporate the general public's comments into our deliberations throughout the course of today's hearings. I'm going to thank my co-chair, Ms. Yamada, and give you an opportunity to provide an opening statement as well.
Thank you very much, Chair Mitchell. I am delighted to join you in this joint hearing about a very important subject to us all. Because we have such a long agenda, I'm going to keep my remarks very brief. I did want to thank my Vice Chair, Dr. Linda Halderman, and also Donna Wagner, who have joined us as members of the Aging and Long-Term Care Committee. It's actually quite an honor for us to be in the big kids room, since many times we find ourselves Aging and Long-Term Care Committee hearings, frankly, in the smallest room in this building. And with a population that will be 1/5 or 20% of this state in a very short period of time, I believe that it is long overdue that we have hearings of this type in which, when given the information in the form of a budget trailer bill or a budget proposal that are really enacting policy decisions, I think it is indeed our obligation to have these kinds of hearings so that we can hear all perspectives as we move California forward. Thank you.
Any other opening statements from any other members of the committee? Okay, seeing none, again, I just want to state that we've organized today's hearing to allow speakers to provide an analysis and background to set the stage before we hear the proposals specifically contained in the governor's budget. Not only will the opening speakers set the context, but also this allows the administration and their departments the opportunity to hear from the community and experts, and to then include responses to some of the issues they may raise in their presentations. Again, I talked about having more than one opportunity for public comment, and we thank you all for joining us for today's hearing. We'll get started with our overview of California's current long-term care system panel and ask panelists to come forward. They include Sarah Stenhansen, Senior Policy Advisor from the SCAN Foundation, Kevin Prinville, Deputy Director of the National Senior Citizens Law Center. And we're going to give you both in the neighborhood of 5 minutes to educate us with an overview of the long-term care system in the state. Thank you very much.
Good afternoon, Chair Mitchell, Chair Yamada, and members of the committees. It's my pleasure to be here today. My name is Sarah Steenhausen, and I'm with the SCAN Foundation. The SCAN Foundation is an independent charitable foundation that's focused on improving the continuum of care so that people can age with dignity, choice, and independence. As you indicated, I will be providing you today basically a background context for your discussion on long-term care integration. And in doing so, I'm going to outline the very basic provisions of our Medicare system, the Medi-Cal system, and our long-term services support system. To begin, I think we all recognize the tremendous challenges that the system faces today. Not only are these systems siloed and uncoordinated, but they lack the capacity to serve consumers according to their needs and preferences. The ideal system would place the consumer at the center of the system and enable access to a range of both medical care and long-term services and supports that help keep people at home and avoid institutionalization. So by looking at the broader system, we can see where there might be opportunities to address some of these underlying challenges. So to begin, I'm just going to provide a very basic background on the Medicare and Medi-Cal programs. Medicare is the federally funded program for people who are over the age of 65, as well as for individuals who have disabilities and meet the qualifying criteria. Medicare pays for hospital and outpatient medical care services, but it's very important to note that Medicare does not cover long-term services and supports that people need for an extended period of time. It's also very important to note that Medicare has very limited coverage of mental health services, and this is going to play out in your discussions and deliberations about the integration proposals as well. Medi-Cal, as you all know, is the joint state-federal program for low-income individuals, including seniors and people with disabilities. Medi-Cal is required to cover hospital, outpatient, and long-term nursing home stays. And in contrast to Medicare, Medi-Cal does cover some long-term services and supports that I will outline for you right now. Long-term services and supports under the Medi-Cal program are commonly categorized into two areas. One are the institutional long-term services and supports that are received typically in a skilled nursing facility type of setting, or two, the home and community-based services that include a range of services provided in the community that we will discuss. So it's important to point out that despite the fact that people overwhelmingly prefer to remain at home and avoid institutionalization, and the services in the community are believed to be much more cost-effective than those in institutions, the federal Medicaid law provides an entitlement to institutional long-term services and supports, but only says that states have the option of covering home and community-based services. So this has created a number of challenges for our home and community-based service system over the years. But California did choose in the 1970s to cover a range of Medi-Cal funded home and community-based services, really many of which served as national examples and were later spread to other states. And these programs, as you know, include Medi-Cal state plan services such as the in-home supportive services, adult day health care, which as you know is transitioning to community-based adult services as part of the 1115 waiver. And then there's a number of other programs under the Medi-Cal program that are home and community-based service waivers that are smaller in scope and not necessarily available on a statewide basis. But it's very important to recognize that an individual's long-term services and supports needs are not just necessarily categorized into one arena. They can range from everything from personal care services to transportation assistance to caregiver support, as well as a range of other services and supports in the community. It's also important to recognize that while Medi-Cal does cover a range of home and community-based services, our state system also offers a number of other home and community-based services under other programs and funding structures, making the system more complex and fragmented. So now what I want to do very briefly is touch on our dual eligible population. Dual eligibles are individuals who are eligible for both Medicare and Medi-Cal, and they tend to be the poorest and sickest in the United States, and they are very high utilizers of both the Medicare and Medi-Cal systems. So the way that it works is that Medicare first pays for the acute and hospital medical care services, and then Medi-Cal provides the wraparound services for services that Medicare does not cover, including long-term services and supports and some others. It's important to recognize, and I know that Kevin will be outlining a lot of this, a lot of the complexity between the Medicare and Medicaid programs, which for the consumer's perspective makes it incredibly difficult to navigate the system and very difficult to access the services that they need, particularly those to remain at home and in the community. So now what I'm going to do is just touch very briefly on our Medi-Cal managed care delivery system, our Medi-Cal delivery system. There are two components to our Medi-Cal delivery system, as you all know. There's the Medi-Cal fee-for-service system, where Medi-Cal participating providers receive payment for each service, and then Medi-Cal beneficiaries can obtain services from any of those participating providers. Then there's the Medi-Cal Managed Care Network, which is a system in which 30 of our 58 counties currently contract through the state with managed care organizations who are responsible for a range of Medi-Cal benefits with capitated payments received per member per month. As you know, there are three different models of Medi-Cal managed care in our state. There's the two-plan model, where the state contracts with both a local initiative and a commercial plan. There's a county organized health system model, where the state contracts with one health plan administered by a public agency. And there's geographic managed care, where the state contracts with several commercial plans in one county. It's important to point out that enrollment in Medi-Cal managed care at this time is voluntary for dual eligibles. Medicare law has established a strong right for Medicare beneficiaries to have choice, and so the dual eligibles have never been mandated to enroll in the Medi-Cal managed care system. However, as you are aware, seniors and persons with disabilities who are eligible for Medi-Cal only are required to enroll in managed care or Medi-Cal managed care plans as a result of the 1115 waiver that I know you will be discussing today. I finally wanted to point out that the benefits covered under the Medi-Cal managed care program do not include, at this point, the range of long-term services and supports that are offered under the Medi-Cal program. So the Medi-Cal managed care organizations are responsible for the provision of medical care services that are provided under Medi-Cal. But at this point, they are not responsible for long-term services and supports. Now, there are exceptions to that, and you all know that as of April 1st, the community-based adult services program will become a Medi-Cal managed care benefit. And there are models out there, like the program for all-inclusive care for the elderly that you will learn about today, that provide an integrated system of care between the Medi-Cal and Medicare systems. So I've given you a very, very quick crash course in the whole system, though I know this is something that you're all familiar with. I just think it's important to conclude with some of the basic, really critical system challenges that we face at this time. California was once seen as a leader in the provision of home and community-based services. As I said, a number of innovative programs were started here. The PACE program, in-home supportive services, adult day health care, and the caregiver resource centers, just to name a few. But despite our early advances, the system has been negatively impacted by a number of challenges, the first of which I've already alluded to, which is system fragmentation. This creates enormous burdens not only at the state structure, state administrative level, but also for the consumer and their caregivers. There's also a lack of capacity to meet the need for home and community-based services across the state. There are many areas that have long wait lists for some of the programs, so consumers have a hard time accessing the services they need. There are issues with state and local fiscal incentives. One example at the state level is that, as you know, programs are budgeted individually. So you have a kind of siloed approach to budgeting, and there's no ability to have a flexible accounting method where you can transfer funds in between institutional and home and community-based services, whereas a number of other states have successfully developed one account for both services. At the local level, the counties have no fiscal incentive to place people in home and community-based services because they pay a share of cost for the in-home supportive services program, whereas they pay no share of cost for nursing home care. So you can understand when counties are strapped fiscally, it's very difficult for them to be encouraged to increase access to home and community-based services when they have to pay part of the bill for it. Finally, our state lacks a comprehensive data system. We gather data individually by program in different ways. The programs don't speak to each other. It's very hard to understand how consumers are using programs across the system, so there's really no picture of where the gaps are and where the inefficiencies are in the system. So in conclusion, we've discussed the importance of developing a system that puts the needs and interests of consumers at the center, and it's important to address the range of long-term services and supports needs that individual might have, and to take time to improve, build upon, and maintain our home and community-based services infrastructure, regardless of how the system changes in the years to come. Thank you very much for inviting me to be here today, and I'm happy to take any questions you might have.
If there are any members who have any questions briefly of Ms. Steinhausen, if not, we'll move on. Seeing none, Mr. Prinville, thank you.
Distinguished chairwomen and members, thank you for having me here today. My name is Kevin Prindiville. I'm the Deputy Director of the National Senior Citizens Law Center. With my time today, I'm going to touch briefly on two issues. The first is I'm going to try to identify some of the challenges that dual eligibles have in the current system. And secondly, I'm going to try to give a little bit of an overview of some trends that are happening at the national level that are very relevant to the topics of today's hearing. So ideally, qualifying for two health insurance programs, Medicare and Medi-Cal, would lead to an improved experience compared to someone who only had one or the other. The reality is that for dual eligibles, misalignments, that many of which Sarah has touched on, actually don't deliver that ideal. But it's important to note that the problems that duals experience aren't always related to the interaction between the two programs. Oftentimes, it's failures of each program respectively. And I'll touch on that a little bit more as we go. So as Sarah noted, the two programs cover different services. They have different standards for covering those services. They employ different program rules for providers, for plans. They have different payment structures. They also come at the problem from two very distinct approaches. Medicare's approach is a much more medical approach. It's an approach which seeks to help people through an acute episode, and that's it. Medicaid and Medi-Cal take a more comprehensive approach, thinking about social supports, trying to help individuals maintain their current functioning. The misalignments between the two programs that occur because of those different approaches can cause huge headaches for plans, for providers, and causes conflicts between payers. The misalignments can also impact beneficiaries' access to services. In particular, duals can have worse access to care than non-duals in the areas of prescription drug coverage, durable medical equipment, and skilled nursing and rehab services. The misalignments can also limit payer and plan incentives to provide increased access to home and community-based services. So some of the impacts on beneficiaries are very real in their day-to-day life, where they're getting less access than they otherwise could. Some of the impact is more on a system level that Sarah mentioned, that there's less incentive to provide the right care in the right place. That's not something the beneficiary might notice on a day-to-day experience, but it does impact their care from a systems perspective. But the biggest access problems that we continue to see for dual eligibles that we hear from are the service delivery problems that arise from limitations within each program. For example, on the Medicare side, Medicare's payment and coverage rules include incentives for nursing homes to essentially shift people back into unnecessary hospitalizations so that they can get a better rate when the person returns from that hospitalization. That's a Medicare problem. On the Medi-Cal side, we have low payment rates for providers that impede individuals' access to doctors. We've also been cutting programs which this population relies on. That's a Medi-Cal problem. And the system, you'll often hear it talked about for duals as a fragmented system, implying that the individuals don't get the coordination of care that they receive. And in many cases, that's true. Most dual eligibles are in the fee-for-service system for both their Medicare and Medi-Cal. There's not an entity being paid specifically for coordination of those activities on a broad scale. But many dual eligibles do receive some level of care coordination now. Some of them are getting about what they need, but others are not. Places that duals currently turn to for care coordination are themselves. Many dual eligibles are capable of providing their own care coordination, just like many of us here today are. Some have close relationships with providers that really do a wonderful job of holding their hand through system and access to services. There's great programs in California that Sarah mentioned, like Adult Day Healthcare and the MSSP programs that provide really intense, really effective care coordination services to dual eligibles. And finally, some dual eligibles have chosen, as they have the choice to, enroll in managed care plans, either on the Medicare side or the Medi-Cal side. Few duals have actually exercised this choice, so it's a question as to why that has been the case. Only 13% of dual eligibles have chosen to enroll in Medicare managed care plans called dual eligible special needs plans. Only about 20% of duals have enrolled in Medi-Cal managed care plans, and actually most of those are in the COES counties where they had to enroll. So for some reason, this isn't an option that duals have been choosing for themselves, even though it's out there as a choice for them. I also want to note that to date, enrollment in managed care hasn't necessarily met an improved coordination for duals. Some plans do better than other plans. Some individuals thrive more in plans than others. Given the problems with the current system, we think the goal of integration has to be not putting together these two systems that are already broken independently in many ways, but rather thinking of ways to design new systems, the type that Sarah talked about, that really put the person at the center, that build a new way of providing care to this vulnerable group. So turning away from the dual eligible experience, I'd like to highlight quickly 3 national trends in Medicaid and Medicare that relate to the topic of today's hearing. It demonstrates that California is really on the cutting edge, but unfortunately that means there's not a lot of experience or evidence for us to learn from in making policy decisions, which I think means that we need to take things slow and make sure that we're making good decisions. The first is Medicaid managed care. More and more states across the country are turning to capitated risk-based managed care models as cost containment strategies for providing care to their Medicaid population. And more states are looking to expand managed care to groups that haven't been covered in the past, like seniors and persons with disability. And California is an example of a state that's doing this. It's important to keep in mind that traditionally that's not how Medicaid managed care has worked. Nationally, about 40% of Medicaid spending on adults and children is in managed care. For seniors, it's only 7% at this point, and people with disabilities only 13%. So those groups, we don't have a lot of evidence about how well those groups are served in managed care. The second trend is Medicaid long-term services and supports moving into managed care. An increasing number of states are looking at, again, capitated risk-based managed care to provide the range of long-term services and supports covered by Medicaid in an attempt to save money and also to shift resources from institutional settings to home and community-based services. Again, there's little experience with these programs. Cost-saving studies on these programs are inconclusive. Even the information we do have is difficult to generalize because each state is so different. Each state starts from such a different place, it's hard to measure growth. Currently, 11 states operate capitated managed care LTSS models, serving a total of just 440,000 beneficiaries in those models across the country. We've also got the successful PACE program, which serves about 20,000 people nationwide. The third and final trend is the dual eligible demonstrations. And much of the move towards managed LTSS in states is connected to the potential of the dual eligible demonstrations. The Affordable Care Act created a new office at the Centers for Medicare and Medicaid Service, often called the Duals Office. It's officially called the Medicare Medicaid Coordination Office. That office invited states to participate in a demonstration with the goal of integrating all Medicare and all Medicaid services, program rules, financing. The demonstration provides two paths to integration. One is the path that California is on, which is a capitated managed care path. The other is a managed fee-for-service path. There's 38 states that have expressed an interest in this, so California is not alone here. California is one of 15 states that got a special contract to help fund the design of a program. Now, under the demonstration, states have to submit a proposal to CMS, and California, I think, is getting pretty close to submitting that. If CMS approves the proposal, the state, Medicaid, and Medicare have to work together to develop the program, figure out how to blend the program rules, what will the rate be for plans, a lot of work that has to happen between the state and the federal government. Under the capitated model that California is going to pursue, there also has to be joint approval by the state and CMS of which plans will participate, and there's going to be a three-way contract between CMS, the state, and the plan. 5 states so far have submitted drafts of their proposal publicly. Those are Illinois, Massachusetts, Michigan, Ohio, and Oregon. Each of those proposals offers to serve between 60,000 and 200,000 people, to give you a sense of scale that other states are taking on. There's a long list of policy development that needs to be developed at the federal level and in the states. A lot of common questions across the states. These include the enrollment process, how to do consumer direction, what will the benefit package be, what will assessments and care plan processes be, continuity of care provisions, appeals procedures, notices, accessible services, provider networks, oversight and monitoring, financial structures, and timing of implementation. These things at the federal level are all still in play. Decisions have not yet been made, so there's a lot of work to be done. Significant and careful work is what it's going to take to get this right, and because of the needs of this population, it's imperative that we do get it right.
Thank you very much to the two of you. This was a good idea because you've cemented us all in a real kind of, we all can kind of step now from a common place of knowledge in terms of what currently exists in the programs, and particularly thank you for the information in terms of the national approach in the other states. And for me, I think the scope, to hear that the other states are looking at, the transition of 60 to 200,000, and we're looking at 10 times that number, is significant. Any questions from committee members? Dr. Halderman?
We know that access is a profound problem for residents of the region I live in, which is the Central Valley, and that is particularly acute in Medi-Cal. Have we seen any evidence then that is occurring in Medicare as we're looking down the barrel of 77 million baby boomers?
There are a lot of anecdotes about Medicare providers starting to leave the Medicare program, but the data so far doesn't bear that out. It's certainly an issue in many parts of California. It's an issue nationally, especially because Medicare payment rates to doctors have become a political football. So doctors, I think, are constantly on the verge of seeing major changes in how they're paid. So we do see growing issues and a potential, as you identified with the baby boomers, for there to be more of an issue for Medicare provider access as well. There is, I think, some promise in the duals demonstrations to improve access to Medicare doctors if the plans that participate are really committed to doing that, to helping duals who sometimes have even less access to Medicare docs than other Medicare beneficiaries because California reimburses at such a low rate, to kind of bring, float all boats up to the Medicare level and Medicare levels of access.
Ms. Yamada.
Actually, the question that I was going to ask very similar to Dr. Halderman's in terms of the access issue in rural communities. I was going to ask Ms. Steenhausen, in your deliberations or discussions, has there been input from the rural counties on how this transition would affect them? Since, if I may, just hold the LAO report and the map showing where managed care does not exist.
Yes, well, yeah, I'm sure you'll be covering this later today, but as you know, the governor did propose to expand the managed care system to the remaining 28 counties that are not currently Medi-Cal managed care counties. And I think it raises a number of questions about how that can happen, given that some of the areas don't necessarily have the capacity that they would need to establish managed care networks, but apparently there are other models that are out there from other states, so maybe forming regional networks. I know that the department may be able to comment on how to approach that, but I think the important point is that right now many people in rural areas currently lack access to many services, particularly on the home and community-based service side. So I think that will be a challenge about how to enhance access in the rural areas that so many people live in.
Thank you very much. We appreciate your presentation. We'll roll into our second panel. That'll provide us with an overview of current major initiatives and stakeholder perspectives. We'll hear from the LAO, Catherine Blakemore with Disability Rights California, Katie Murphy, Neighborhood Legal Services of Los Angeles, Dr. Brad Gilbert with the Inland Empire Health Plan, Dr. Patricia Samuelson, who's a practicing physician and is representing CMA today. Thank you very much, and I'm going to ask you all to limit your comments to 5 minutes each. We'll start with the LAO.
Thank you, Madam Chair. Sean Martin with the Legislative Analyst's Office. We were asked to provide a high-level overview of 3 major initiatives. The first is the transition of adult day health care to community-based adult services. The second is the mandatory transition of seniors and persons with disabilities into managed care. And the third is a dual-eligible pilot project, also called the demonstration, that was authorized to implement a coordinated care project in up to 4 counties. Before we cover those, we were also just asked to briefly touch on some of the proposals in other departments that would affect seniors and persons with disabilities.
So you'll have extra time. Don't tell everybody else.
Okay.
Because we did ask you to cover a lot, so 5 minutes doesn't apply to you.
So thank you. The first is in the Department of Developmental Services. The Governor is proposing to achieve $200 million in general fund savings through a work group process in which a work group will try to identify strategies to achieve that savings target. Another proposal that the Governor has that we believe would affect seniors and persons with disabilities would be the elimination of caregiver resources centers that provide supportive services to care to people with cognitive impairment such as Alzheimer's, stroke, or traumatic brain injuries. And then a third proposal that we believe would affect seniors and persons with disabilities. Indeed, the Governor proposes to eliminate domestic and related care services for most in-home supportive services recipients who live with another person. And this is estimated to save about $164 million general fund. So now I will give a high-level overview of the 4-county dual eligibles demonstration. Federal policy has been aimed at providing better coordinated care for dual eligibles. The Patient Protection and Affordable Care Act has established 2 new federal offices, the Federal Coordinated Care Office, also called the Duals Office, and also the Center for Medicare and Medicaid Innovation. I think Mr. Prinville, who just testified, covered a lot of issues regarding what these offices are doing, so I'm just going to skip that part. I do want to say that the state legislation creates a duals demonstration that has yet to begin. The legislation authorized the state to implement a coordinated care pilot project for duals in up to 4 counties. The legislation requires the demonstration to include at least one Medi-Cal managed care county. It's a county organized health system, and another county that is using the 2-plan model. In selecting the sites, the legislation requires DHCS to require first local support for to consider first local support for integrating medical care, long-term care, and home and community-based services networks, and second, a local stakeholder involvement in the development and implementation and continued operation of the demonstration. Let's see. The Department of Health Care Services is currently in the process of reviewing applications for participation in the demonstration project. The announcement of the selected sites is expected in mid-March. And now my colleague, Felix Su, will give an overview of the Adult Day Health Center's transition to community-based adult services, and also the mandatory transition of seniors and persons with disabilities into managed care.
Before you start, if we could ask the sergeants to turn up the volume. I see people in the back of the room straining to hear. And if all the panelists could be mindful to speak up, because we've got a full house today. We will make sure everybody hears you. Thank you.
Thank you, Madam Chairs and members. Felix Su with the Legislative Analyst's Office. Most of my remarks today are going to follow the organization of the handout that we provided that you should all have a copy of so you can follow along as I go through the presentation. As you can see on page 1, our handout goes into quite a bit of detail, both on the background of the Medi-Cal program, as well as beneficiaries who are seniors and persons with disabilities, much of which was covered by the speakers in the first panel. So I'm going to skip ahead to page 4 of our handout and actually start with the second checkbox on the Adult Day Healthcare benefit. ADHC is a Medi-Cal optional benefit that's currently administered under fee-for-service. The ADHC program consists of an outpatient daycare program for adult SPDs who may be at risk for nursing home placement. The services are provided by licensed facilities known as ADHC centers. On page 5, we point out that in January 2011, the governor's budget proposal package included the elimination of ADHC as an optional benefit. In March of 2011, the governor signed legislation that authorized this elimination. In July of 2011, the governor vetoed separate legislation that would have created the Keeping Adults Free from Institutions program. This program would have generally used existing ADHC centers to continue providing services for certain classes of Medi-Cal beneficiaries. In his veto message, the governor indicated that his administration would instead pursue a different strategy for transitioning ADHD beneficiaries to other services. In August of 2011, the Department of Health Care Services unveiled this alternate strategy, which included the passive enrollment of the majority of ADHD participants into Medi-Cal managed care. From mid-August through October of 2011, the department began to implement this enrollment strategy. Moving on to page 6. In June of 2011, a group of plaintiffs filed a class action lawsuit on behalf of all ADHC participants across the state, challenging the elimination of ADHC as a Medi-Cal optional benefit. In November 2011, DHCS and the plaintiffs jointly announced that they had reached a settlement agreement that was approved by the district court on January 2012. The settlement allows the phase-out of the ADHC benefit and replaces it with the Community-Based Adult Services Program. On page 7 of the handout, we outline some key characteristics of Community-Based Adult Services, or CBAS, as detailed in both the settlement and subsequent guidelines issued by DHCS. CBAS services are substantively very similar to the services currently offered under the ADHC benefit. Moreover, they will be provided in former ADHC centers that will convert to licensed CBAS providers. It's important to note that starting July 1st of 2012, CBAS will become a benefit that's only available under managed care in counties that offer Medi-Cal managed care. CBAS introduces additional eligibility requirements on top of those that are currently available or in place for the ADHC benefit. The Department of Health Care Services is responsible for making initial determinations of who will be eligible for the CBAS program under these new requirements. The department has proposed to implement the CBAS program under an amendment to the existing 1115 waiver. In February of 2012, the department announced that the Federal Centers for Medicare and Medicaid Services needed additional time to process the waiver amendment, thus shifting the effective elimination date for the ADHC benefit till April 1st of 2012. On page 8, we switch gears and begin discussing the mandatory enrollment of SPDs into managed care under the 1115 waiver. The federal government approved this waiver in November 2010. It includes the state's intent to mandatorily enroll up to 380,000 SPDs with Medi-Cal only coverage in 16 counties under a phased-in 12-month transition. On page 9 of our handout, we point out that in October 2010, legislation was enacted that permits the department to proceed with the enrollment process as proposed under the Bridge to Reform waiver, subject to reporting requirements to the legislature. Page 10 provides a high-level overview of some of the key components of the second semi-annual report from the Department of Healthcare Services to the legislature. This report covered the 6-month period leading up to the first month of enrollment for SPDs in the 16 counties. And it covered activities including a review of each managed care plan's readiness to both receive and begin serving SPD clients, the notification strategy for beneficiaries as well as community stakeholders, a data exchange with health plans to begin developing risk assessments for their incoming SPD members, and final federal approval of the contracts between DHCS and the managed care plans. Finally, the report also indicated that during the first month of enrollment in June 2011, the DHCS had begun to receive several requests for medical exemption from managed care plan enrollment from both SPDs and their providers. At this point, I'll conclude my remarks and open it up for any questions that you may have on any of the 3 transitions that we've talked about today. Thank you.
Thank you very much. Are there any questions of the LAO before we hear from the rest of the panel? Okay, seeing none, thank you very much. First witness.
Thank you, Madam Chairs and ladies and gentlemen of the legislature, for having me here today. My name is Katie Murphy, and I am managing attorney at Neighborhood Legal Services of Los Angeles County. We are a member of the Health Consumer Alliance, which represents individuals who are low income and need help with health and a number of other issues throughout the state. My office in Los Angeles County has been struggling very much with this transition. I've been asked to come here today to talk to you about the experiences of our clients. I note that 3 months ago I was here in this very room for a health committee, and I wish I could tell you that it's gotten easier for our clients. I wish I could tell you that they're having an easier time. I wish I could tell you that when the Department of Health Care Services said we're learning lessons, that we could see any evidence of that, but we are not seeing any evidence of that. And I really want to tell you some of our clients' stories, tell you some of the experiences they're having, ask you to please slow down with these new phases and really try to learn from this SPD transition, because it is a much smaller and much less complicated implementation, and our clients are really suffering. This has been the most challenging, most time-consuming, and least successful effort by our advocates in any Medi-Cal program implementation in the last 14 years. Our advocates struggle. They make dozens of calls to file grievances, have appeals, and we lose. We are not winning on behalf of our clients very often, and this is a system failure. We have clients who are patients who need to keep their doctors, who need to have transition into their plans with their doctors, who are just not getting it. We have patients who are having to start over in their plans, and plans who do not have good information on their patients' histories. I think the department implemented this very quickly, and there are a lot of lessons that we could learn from this and try to do this next implementation more slowly. Over the last 10 months, we're now in the 11th month of implementation, we have seen patients who, I will tell you, we do not counsel patients to file an exemption request to stay out of the plan unless they really need it, unless they meet the criteria in the regulation, which says you have a complex or progressive medical disease, or you have a treatment plan that cannot be interrupted, you have a doctor who says there will be deleterious effects and they are unstable to move, or they have a particular listed condition. We do not file those exemption requests or encourage our clients or their doctors to do so unless they meet that criteria, and they're almost universally denied. There is no meaningful access to the exemption process for our patients. They're being denied across the board almost entirely. We have several hearings pending, and I'm going to give you some examples in a minute. There's really not been meaningful implementation of the continuity of care procedures. I know some plans have done this a little bit better, and you're going to hear from Dr. Gilbert, who I think his health plan is held out as a model. I want to just tell you that our plans are working very hard at this, but they are really struggling in LA County to integrate this very complicated patient population. We have severely medically needy patients with delicate treatment plans who are having to start over and case manage their own care when they come to a plan, because the plan does not have good information on them. I do not mean to bully our two plans. There are many things they could do better, but they have not been given good information, and they cannot authorize or continue a treatment authorization request that they have no data on. And so the patient is left having to tell their own story, often someone with complex medical and physical and mental health and physical conditions, not the best person sometimes to be telling a complicated medical story. They do not have the health literacy for that. I want to give you a few examples. The names are changed. We handed out a document. The names are changed for confidentiality of our clients. First, Norma. She's 47. She lives in Wilmington. She lives on 854 of SSI. She is paralyzed on her right side due to a gunshot wound, severely disabled, severely injured, missing her right eye, and her eye socket is collapsing. When she was defaulted into a plan in September, she was awaiting surgery at Harbor UCLA Hospital. It was scheduled. That right there should have been grounds for an exemption. She did not. Her doctor, something happened, and we don't know why her exemption was denied, but it was. And by the time she came to us, she had been in the plan too long to file a new exemption request. She also should have been able to stay with those doctors and get to continue with the surgery. She's having severe pain in her eye socket collapsing, but she was unable to do so. She says to our advocate, I know the pain must be really bad because I'm paralyzed on this side. I'm not supposed to be feeling pain. When she came to us, she had gone 6 months without pain medication, without access to specialists. Our advocates filed multiple plan grievances for her. And finally, we were able to get her back with the very same provider through Harbor UCLA, and she now has an appointment with the surgeon on April 12th, over a month away, surgery not yet scheduled, which is the same place she was in back in August when she was defaulted September 1st. It took a lot of work, dozens of calls from our best advocate on this to even get to this place, and multiple plan grievances. Now she's getting referrals to various doctors, and our advocate has also asked, can we please get case management for her? She needs coordinated care. And the grievance department person says, oh, this is a really complicated case. And we say, exactly. That is why the plan needs to do some care coordination for her. Marta is 61. She lives in Los Angeles. She has Medi-Cal linked to her SSI. She was one of our first SPD patients, and she's been struggling with one issue after another. When we got her on, she finally did get continuity of care, and once she got it, the legislature has guaranteed her 12 months to stay with her doctor once the doctor contracts with the plan, but then the plan said, we can really only do this for 3 months now that you're in, and you can only see your doctor once a month, even though we know that you've been seeing the doctor once every 3 months. And so she has a scheduled cortisone shot that she needs for her pain that the plan is telling her she's going to have to pay out of pocket in order to do it because the plan doesn't authorize this. This is something that we should be able to work out for these patients, but it's not being worked out without tremendous advocacy. I want to also update you on, at the legislative briefing I did recently, I talked about a client named Anton, that's not his real name, who has severe uncontrolled paranoid schizophrenia and severe uncontrolled diabetes and is so afraid of going to new doctors. His doctors have written letters to say he has made 3 suicide attempts because of changes in his life, such as moving doctors, and we are very frightened that going to a new system of care he is not unstable. These are the deleterious effects. Suicide is the highest price we can pay, and the plan denied his exemption. The state denied his exemption. We have an appeal on that coming up. We have asked for an expedited review, which was denied. This is a patient who has a severe eye infection right now. His doctor, who he's still talking to, even though the doctor's not getting paid because he's in the plan, the doctor is saying, this is very dangerous for you. You have to come in. And this is someone who goes without medical care, without this sort of attention. I want to just say a couple things. This was a small implementation. These are a few examples. We have dozens and dozens a week like this. These are real people who are struggling to figure out how to coordinate their own care. There are lessons lessons we can learn. I'd like to say 3 things in terms of my recommendations, if I could make them. 1, study this, learn from this. When I was working at the Western Center in the past and we would want to do something very proactive, the legislature would say, well, let's study it. We think you should study this. We think there should be time here. We should build this in, especially when human lives are on the line. Related to that data, and data from all sides, data from the providers, from the patients, the real information about health outcomes. If we can't afford to take the time to get the data, we are going too fast. And slow down and do this in stages. This is something where these patient stories are going to evolve, and the more we can learn from that, the more I thank you for your time and your attention to our patient stories, their lives, and everything that means for these proposals. Thank you.
Thank you very much. Thank you very much. Dr. Gilbert.
Thank you, Madam Chair and members of the committees. I really appreciate the opportunity to talk. I also appreciate the nice comment by Katie. I think having a lawyer make a nice comment about me is pretty good. So I am a physician CEO, but I'm a doctor first, and I want the commission to be very clear. That's how I think. I'm a doctor. We're the not-for-profit local initiative. We have about 540,000 members, of whom 20,000 were seniors and persons with disabilities that picked us voluntarily before mandatory enrollment. We also have 7,000 dual SNP patients, so we have the Medicare side as well. So Kevin said not too many choose. 7,000 have chosen IEHP. 1% disenroll. So we must be doing something okay. So I want to talk a little bit about the lessons learned from SBD and CBAS, but I also want to talk a little bit about how frustrating it is for us with our members now. If they need mental health and they're a Medi-Cal patient, we say go over there to the county. If they need in-home supportive services, we say go over there. If they need anything that's outside the benefit, Medicare on the Medicare side or outside our Medi-Cal benefit, we have to say go over there. And we help, we do phone calls, we try to make it happen. But ultimately, Kevin and Sarah's point was it's not integrated at all. So let me talk a little bit about SPDs. And Dr. Haldeman, you had a really important point. Access is totally critical. And by the way, the Central Valley and the Inland Empire, 2 worst counties, areas in the California for primary care physicians. We have the distinction of being at the bottom in terms of the PCP ratio. So absolutely critical to making her anecdotes work is having a network of physicians that will care for these patients. So we did a couple of things, and I want to tell you specific things we did that we think made it better. Number 1, if they had an authorization within if they were going to a visit, a surgery, anything in 48 to 72 hours, didn't matter where it was. UCLA, City of Hope, contracted provider, non-contracted provider, approved, period, end of story. Because you don't have time to figure out in 48 to 72 hours. If it was longer than that and it was a non-contracted provider, then we would work on it and try to figure out what was going on. Second, there is no reason that any health plan would want to not get the people the care that she was talking about. Why would it be in our interest to not provide care to such vulnerable people with the risk, I'm going to take the non-doctor position, with the risk that they could get sicker and do worse. So from a motivation point of view, there's no reason to not take care. And anecdotes are really important, but I think we got to look at systems. Second thing we did, every plan has a drug list, a formulary. Those meds you get right away. Others you have to get a prior auth. We changed our formulary for these members because the Medi-Cal formulary, which by the way is not a very good formulary, has more brand drugs on it. We added those brand drugs to our list. So we avoided 500 to 700 prior authorizations per month, meaning the patient walked up with their prescription, got it, instead of going through the prior auth process. So there are things you can do using data, using common sense in some cases, to really make the transitions better. And I also disagree with quantity. We're getting 3,000 members a month. Every one of those 3,000 members is complicated, has medical issues. Do we take care of them, all of them perfectly? Are there problems? Of course there's problems. But it's our job to make it work. So I would disagree. I think 3,000 people a month, because the difference is many of them didn't choose to come in. So that makes it a little bit harder. So I think the other thing we did was we created a special triage team, nurses and coordinators. Person calls member services, has medical issues, immediately transferred to our triage team, kind of like an emergency room, where you see the nurse first, takes your blood pressure and figures out what needs to be done. So for SPDs, I think it has gone reasonably well. That does not mean that individuals didn't have issues, that there were problems, but I think we've done a pretty good job. CBAS. The way that's going to work is we have initiated contact with every single one of our ADHCs. We brought them to the health plan. We talked to them. We went on site so that we could together help their members understand. You all remember that time frame when it's in, it's out, it's in. The key there was really good information. So the way that worked was us connecting directly to those CBAS centers. So last, I'll focus on the duals and why this is a good thing. And I think you've heard the hypothetical reasons why. The integration of care being so important. You've got to be able to provide a member the entire range of services. If you have to say, go over there, they don't always go over there. And when they go over there, they don't always get what they need. If you give it to a health plan, and I mean in a sense, we can organize that care, and that's our job to do that. 4 or 10, neither of those are magic numbers. 4 was an arbitrary number in SB 208. 10 is a number from the department. To me, your key is how many qualified, capable health plans are out there. Who has done this work? Who has taken care of Medicare patients? Who's taking care of Medi-Cal patients? Who can make this work? That is what I think how you should think about it, not 4 or 10, because those are arbitrary numbers. Finally, in-home supportive services, absolutely critical to this process, absolutely critical to keep members in a good place in the community. I think we need to leave it alone and leave it as is initially. I think we need to be very careful with it because we do not want to interrupt the care that individuals are getting. So I think we need to, the only thing I would add is for high-risk members in IHSS, I'd send out one of my team with the county social worker to do that assessment. So that's probably the only thing I would think of in terms of changing. So to conclude, integrating cares and services is absolutely the right thing to do. There are qualified and caring health plans out there that will do a good job. I don't know what the number is, but it's probably somewhere between 4 and 10 at some level. And finally, some of these transitions were difficult, but if you approach it right and you use common sense and we're not motivated to not take care of people, I think we can do this. I think we can do this.
Thank you very much, Dr. Gilbert. We'll move on to Dr. Patricia Samuelson, representing CMA today.
Thank you. Yeah, thank you for having us here. I'm Patricia Samuelson, and I'm a native Sacramentan. Went to Sac High and left for college and medical school, and I've been living my dream to return and take care of Sacramentans, impoverished and disenfranchised for the last 25 years, and teaching others to do the same. I'm going to try and walk you through a little bit what it's been like as a physician trying to take care of people during this transition, just kind of the nuts and bolts of what we've found, shall we say, problematic by talking about some of my patients. One of my patients, well, I would use a name, but it'd be phony, so I won't use a name, has advanced immunodeficiency, and she's been stable on gamma globulin every 2 weeks for a number of years. When she was enrolled into a managed care plan, we had to submit authorization requests to continue her immunoglobulin. This was denied. So we resubmitted. This was denied. She didn't have low recent immunoglobulin levels because she'd been getting immunoglobulin. So we appealed this, and a number comes on the form that denies it that has a phone number for me to call and a doctor's name to talk to. So I call that phone number and that extension. It doesn't exist. I called through another mechanism and ask about this doctor because I'm able to find the office. There is no such doctor there. When I finally do reach a doctor and I give him a brief synopsis, within 30 seconds he, of course, okays this. And the plan approves the treatment at an institution with which they do not have a contract. And at this point, the patient, who has been unable to leave her home for months for fear of coming in contact with other people, including her grandchildren, is pretty darn despondent. Another patient has suffered, a longtime patient, horrific injuries and has getting repeated surgeries. She needs over 20 medications a month. So I filled, and we were told that the plans had to continue the chronic medications of these people. Well, I guess they didn't tell the plans that because I filled out 20 pages of requests on this patient. And the problem isn't that they don't cover these drugs. I'm mostly prescribing generics. I'm trying to be thrifty, take care of her as economically as possible and meet her needs. But she can only have 7 a month. So I filled out 20 pages of forms, and I wish I could tell you it's the only person I've done this for, but that wouldn't be true. And they're denied on the basis that they're already covered medications. I explained on the forms that the problem isn't that they're not covered. The problem is that she needs more than 7. Some of them will allow them to have more than 7, but only through a mail-order pharmacy. Some of my patients have had the experience with the mail-order pharmacies that, number one, there are significant delays. Number two, they come in containers that are not child-safe. And my patient does have children. They can be stolen from your mailbox, and then you're just out of luck. And most of all, from the standpoint of a physician, or these complex patients who are having repeated surgeries and infections who need new medications on a regular basis, it just doesn't work for them to be limited to 7 a month or a mail order. We can't meet their needs in a timely fashion. Another patient I had halfway through a course of treatment for hepatitis C. When we put in prior authorization for her interferon, and the plan said it was the group to whom they had delegated the care. The group said it was the plan. When we went, after a few months of going back and forth on this and getting it okayed, she's been off treatment so long that she is in viral relapse. We are now starting over, and she may have permanently lost her chance to be cured of this illness. Patients I've had for many years find out that they have a new plan and a new doctor, actually, when they show up to fill a prescription or when they come to an appointment with me. Unfortunately, even if when they're trying to get back with me, they may have needs so urgent they need to go to this new provider who has no records on these extremely complex patients, nothing on which to request authorization for the medications that are keeping them alive. One such patient who has come back to me now finally very ill, having been some time off a particular medication, Revatio as it happens, when I put in a request noting his diagnosis of pulmonary hypertension, his deterioration without this medication, they came back with, I didn't include a catheterization report showing his pulmonary arteries, etc. I mean, there were a list of 5 things which led me to have to requisition archived records from elsewhere, go through 4 volumes and flag the reports they requested to be submitted to keep this man alive.
30 seconds.
Okay, thank you. I would be sorely tempted to go on, and I certainly could, but I'll just wrap up with saying that these are the kinds of things that are not exceptional. This is this week for me. It goes on, and if there's any way, whether it's the plans need more resources or more time, if we could not do this again, it would be great. Thank you very much.
Thank you very much for your time and testimony. Catherine Blakemore with the Disability Rights California organization.
Thank you, both chairs and members, for being here and taking time to hear about these important issues. I was asked to speak about the CBAS program, the transition from ADHC. We are the Protection and Advocacy Agency for the state of California. We're mandated to protect the rights of Californians with disabilities. We're also counsel in the case, both that stop the adult day health care cuts as well as the in-home support services trigger cuts. I'm not going to summarize sort of the status of where we are with CBAS. I think the Legislative Analyst's Office did a nice job of that, so I'm going to just try and be brief and give you our perspective of where things are. First of all, I want to say that I think in the settlement we reached a good policy resolution. We were able to continue services, continue them uncapped by moving them into an 1115 waiver, and that is a good outcome for Californians that need center-based services. I'm also pleased that the department's initial reports to us indicate that of the current people that are on adult day health care, 70 to 80% of them will remain eligible for CBAS services. That is significantly higher than what the department thought when they first entered into the settlement with us, which was around 50%. So we view that as a good sign that the assessments are working in a way that include more people than maybe the department initially intended or thought would be included. I also think that what we learned is that doing this process and assessing 35,000 individuals is incredibly complicated and really quite challenging to do it under the timelines in the settlement agreement. It's, from our perspective, good that the waiver has yet to be approved. That gave us all another month. We're working with the department on some issues that we think are in need of resolution, and we're hopeful that we'll be able to resolve it with them. That includes the presumptive eligibility reviews, where individuals were to look at kind of the IPC, the individual plan of care, make a determination if they met the eligibility criteria, and then they would be presumptively eligible with an assessment to follow sometime later. The advantage of that process to the beneficiaries, the participants, was that they would get aid paid pending. They would remain in that program during that period of time. There have been some difficulties with that in terms of the approach, and we're hopeful that we'll be able to resolve that with the department. We're also concerned that there are disparities between the list provided to the providers of who is eligible. So providers got a list that said, you know, this 80% of people in your program are eligible, but that list doesn't quite match with the list that was provided in terms of the notice to the recipient. So there's some disconnect, and we think it's important to slow down and make sure that the list that the providers are getting are consistent with the notices that are going out to the to consumers. And then finally, we're concerned that in some areas, such as in Bakersfield, an ADHD center is closing. 35 individuals are eligible for services, and we think it's very critical that, because there aren't other options, aren't a lot of other centers in Bakersfield, that the department help identify ways in which those individuals' needs can be met. So what I want to say just in closing, and it's consistent with what people here have said, is that we know you can make good policy, but making good policy takes time. There are a lot of moving pieces. It's, you know, it's not just financing, it's what's good policy for beneficiaries, it's, you know, what are the roles of different agencies, what data do we have, and that you can't really make good policy if you're moving too quickly. And we also think that you have to take time to learn the lessons from the work that we've already done. So you've heard people talk about difficulties folks have experienced. So, you know, it can be done well, but it takes time to do it well. And these are people who need services, for whom disruption can be really quite detrimental to them and ultimately lead to their death. And so we collectively have a responsibility to slow down, make good policy, and implement the policy in a way that will have good health outcomes for all Californians. Thank you.
Thank you very much. Mr. Monning.
Thank you, Madam Chair. I want to thank the co-chairs for organizing this. I also appreciate the organization of panels. I think it's very helpful for us to get this information and update. As Ms. Murphy mentioned, we had a joint health committee hearing, Senate and Assembly, in December, hearing some of the testimony about the challenge of transition, people running into brick walls, trying to exercise the exemption. I think, you know, the overall composite here is integration in theory is good. The challenge is how rapidly do we move, and for me the centerpiece has to be first and foremost protecting patient health, safety, and long-term care outcomes. And when we have the incentives often being driven by budget considerations, I think it is our job as the policymakers through this oversight to make sure that we're not pushing too fast. We'll hear from some other panels where I think we'll ask those questions about scale and scope of growth. But I did have a specific question that I wanted to direct to Dr. Gilbert. I'm carrying a bill, AB 1553, and it's to try to better codify the Medi-Cal exemption request regulations and criteria. Because if we continue to hear of individual narratives, which we need to hear, they're compelling, but we need an institutional way to respond to what are individual shortcomings, right? Shortcomings that affected individuals. So my question to Dr. Gilbert is not necessarily in your answer today, but an open invitation to all of you to help us inform what would be the institutional changes necessary to try to protect against the individual adverse impacts that we're hearing. One that you suggested, I think, was a suggestion that you would have a certain automatic default of granting an exemption if somebody had a procedure scheduled within 48 to 72 hours. So it's ideas like those that I think could inform how we get a more effective institutional response to try to prevent these individual impacts. But I was wondering if you have any short comments that would further inform what can we do that would make this work the way it's intended to.
Yeah, I mean, the fact is that not everybody should be in the managed care system. There are individuals that absolutely, in my judgment as a physician and our judgment of the health plan, need to have a medical exemption. Now, the 48 to 72 hours, what I was talking about was an automatic authorization, so the member gets that care regardless of where they are. But in terms of the medical exemptions, I firmly believe there needs to be a fast, fair process. And frankly, we're often advocating as the health plan. And we don't do it because it's an expensive patient we want. We do it because we think it's the right thing to do. So I think that process could be improved, and I think it's the right thing to do for certain people.
Yes, Ms.
I could just jump in on that. I think the reason that your bill is needed is because there's been an implementation problem with the regulation, and there is a small piece that the department has driven a truck through, which is that they're questioning the doctor's determination of the patient's stability. And I think the fact that they're not following the regulation is the big issue here. The doctor's determination of stability is written right into the regulation, but instead the department is making its own medical judgment.
And that's very well framed, I think. And again, whether it's looking at existing health plans that second-guess a doctor's decision-making, we, again, need to protect this through the lens of patient care, quality of care, and respecting doctor's diagnosis and recommended treatment patterns. And if I could, Madam Chair, just a final question, if I might, to Dr. Samuelson. I'm just curious, what is your practice? Are you in a private practice, a group? What's the nature of your medical practice?
I see outpatients at a hospital-supported clinic in the North area and inpatients teaching residents.
Great. Thank you very much, and thank you for what you were able to share today as well. Thank you, Madam Chairs.
Any other questions? Dr. Pan?
Yes, thank you so very much. Dr. Samuelson, I think it's good to see you again, and appreciate your presentation. I think as you were struggling through these patients in the past week, were you able to receive any assistance from the department, or was there any indication the department at the state had any awareness that this kind of situation was going on, and or was there any attempt by either your office or others that you were aware of to communicate to the department the fact that you had these patients who were having these significant disruptions in their care and impacts on their health?
Thank you. Are you referring to the Department of Managed Health Care?
Well, I guess, yeah, our Department of Health Care Services, appropriate state department, is overseeing the transition.
You have to go through the entire process first, which includes a fair hearing, which unfortunately also does build in a time. So no, in these I haven't. We did go to that degree with the patient with immunoglobulin, and at that point we actually, with the immunodeficiency, but we had to follow the process. That's what takes so long.
There is one other option that's available, which is the ombudsperson. So there is an option for members to directly call the ombudsperson to get assistance. Dr. Samuelson is correct, though. Most times members go through our grievance process and we resolve the issue, and if not resolved, then they have the fair hearing, or they can go to DMHC for an independent medical review. But there is this short circuit through the ombudsperson.
Mm-hmm. And does the ombudsperson actually have the authority to instantly make a decision to try to resolve the problem?
No, they call us. But we never want a phone call from the ombudsperson. I mean, 'cause
Let's put it this way. Unfortunately, I think Dr. Samuelson's stories both not only struck too true with me as someone who's a practicing physician.
If I might, yeah, my patient did call the ombudsman and were told they need to follow the plan's process.
Miss, go ahead.
Extremely helpful. I will tell you that they just do have limited authority to solve those problems. Our advocates get a lot of information, and sometimes there are smaller problems that ombuds can jump right in and help. So if there's a technical problem, for example, so it's a tremendously good service, and if it were staffed better, a lot of the smaller level problems could be handled there.
Or given more authority.
Yes.
Ms. Yamada.
Thank you, Madam Chair. I just had a question, actually, for those of you who provided some specific examples of cases that you've been battling through, anecdotal or otherwise. Do you have any data as to how many of these patients ultimately went to emergency rooms, which are actually higher cost than if we were managing this situation a little more carefully? Any anecdotal or otherwise evidence? And I think if you can't read where I'm going, what I'm saying or suggesting is that as we proceed through the review of how we have done thus far in some of these very smaller populations that we've been talking about, if we're actually resulting or causing cost shifts to other parts of our state, we're not really saving the state money. And, that's not my primary interest. My primary interest is to make sure that we are not only saving money, but also providing the best care for the most vulnerable people in our state. But any anecdotal evidence there?
Unless it's anecdotal, yes, but unless I'm the only physician in the state of California to whom this is happening, this is a big problem. It is not rare when we are in the process of requesting authorization for a particular study, in particular, such as a CT scan or some of that nature, to get a result of that exact same study from an emergency room. The patient, and this of course contributes to overcrowding, the patient has not been able to wait as long as it takes to get the authorization and has now gotten the service provided on an emergency basis in one of our emergency rooms because they were not able to wait that long.
Which is higher cost.
Oh, high cost, poor quality, fragmented, and overcrowding our ERs.
I'm trying to make eye contact. Any other questions? Ms. Grove?
Thank you, Madam Chair. So I have just a few questions. Based on the lawsuit that was you guys have talked about and given testimony on it, somebody made a statement that said that 60 to 70% of individuals had their rights restored. What was the percentage before the lawsuit?
So what I was comparing is how many people that currently receive adult day health care are now eligible for CBAS, because CBAS, in fact, has more stringent criteria. So of the 100% of the people that were eligible for adult day health care, it looks like 70 to 80% of those will be eligible for the new CBAS service. That was higher than what the department initially estimated of only being 50%.
As someone who's a direct delivery of services, I'm not talking bureaucracy, I'm talking you have day-to-day direct delivery of client services, hands-on experience. What's better, the adult daycare healthcare system or the new CBAS system?
Well, I guess, it's so the service itself, the services themselves that are available are the same. So for those people that are eligible for those services, it should be seamless and the services shouldn't change. The differences are a more stringent eligibility criteria, which means some individuals will not receive that service. That's not a good outcome for them. And the pool of providers may be somewhat smaller because there's generally a requirement that it be a not-for-profit, and some current ADHC centers are for-profit. And then I spoke of examples of centers that are closing. And in some areas, particularly more rural areas, the closure of a center will have a bad outcome for those individuals, unless, as required by the settlement, the department comes up with an alternate way of providing kind of unbundled services. And, we're currently talking to them about that.
So as an ultimate goal or a better delivery of services to clients or participants, was the adult daycare center better, or under the new CBAS program, is it better?
So I guess to the extent that you want to serve as many people as possible, then adult day health care accomplished that.
Better.
Better, because more people were served by that program than will be eligible under the CBAS program. And I guess the only thing I'll say, though, is when compared to what the administration's initial proposal was, which was eliminating it entirely and providing nothing, then CBAS is going to be better than that.
I get it. It's kind of like a divorce. You ask for everything in your neighbor's stuff and you settle for half and you get, I get it. It's like the path of least resistance. So I guess I have another comment or a question. What is, I guess it'd be the medical provider and the attorney is who I'd want to ask this question to. When you look at delivering your services. Okay, 2 medical providers. Sorry, sir. The medical providers and the attorney. So delivering services and advocating for services. Ms. Yamada asked about the cost that would ultimately end up in our emergency rooms. Especially you, doctor. You mentioned the fact that people come to you and they've gone into remission, or that they haven't, had the proper medical care for several months. You've advocated for services. When you have to start somebody over, for instance, on Hep C medication, or, other medications that you have been adequately providing for these services for these individuals, what is the cost to start over again? Because government bureaucracy has interfered in the delivery of care between a medical provider and the people that they serve.
Well, I can't say, but it's certainly, just for hepatitis C, it's in the thousands. The medication is very expensive. They're halfway through what should have been potentially a 6-month course of treatment. Now in full viremic relapse, you have to start over with induction with weekly labs at first, and it's going to be a minimum of 6 months if we get the kind of response that we got the first time. And maybe it's now a 9-month course of treatment. Maybe it's a 1-year course of treatment. Maybe she doesn't clear. This may have been the opportunity lost, but it will be many thousands of dollars to find out, possibly tens of thousands.
Thank you.
I think
yes, sir.
Very well taken. Either way, the plan is paying for it. So either way, whether they go to the emergency room or have to restart Hep C treatment, and in fact, it would be very expensive to restart, we're paying for it. So forgetting that I'm a doctor, CEO trying to keep my plan financially afloat, why would I do that? And I don't disagree that it happens. I mean, please understand. But my motivation should be to keep that person on their therapy, get them cured, and then from a cost standpoint, that's the best outcome. But her anecdotes are real. These things happen. They're very unfortunate. But even we don't want them to happen. It doesn't make any sense from the plan perspective.
But what I'm trying to wrap around and get my mind around is that last year these votes that changed this structure of the way that you guys deliver care and services to an individual has caused this chaos that has caused people who were ultimately getting treatment that their doctor recommended without government's assistance to recommend, by the way, is now in a chaotic situation where you had to file a lawsuit to just obtain care for an adult daycare situation, and not just the medical side of it, but to serve 60 or to 70% of the people, where before the plan served 100% of the people, but was changed under bureaucratic rules that now you are trying to comply with. Under the old rules, was it better for you as deliverer of services, care providers to the individuals that I look out and see in that audience? Was the old system better?
That's, of course, a very difficult question, but let me give an example, just taking CBAS. We have 409 of our members that are in ADHCs. Only 2 are not going to receive the services. And what we're doing with the CBAS centers, we're going to have a contract that has 2 parts. The ADHC services for those that qualify.
Right.
And other services for those that don't. So we're actually, again, it's in our interest as the plan, even if they're not eligible for the CBAS, to possibly provide those services because it makes sense. But so from my perspective, because I run a plan, I'm a doctor, I believe in managed care, I think we can do a better job for most, but not all people. Some people need the medical exemptions and need to be outside the managed care system.
Okay. Yes, ma'am.
On your question about cost, just a couple things on cost. We have absolutely seen folks who go to the ER who don't need to for things like office visits because they've been limited how many times they can see their doctor, for things like basic drugs and prescriptions where the Medi-Cal program under fee-for-service had authorized the drug, but the plan does not do what Dr. Gilbert's plan does, and they are not automatically honoring that prescription. For things like cortisone shots, those are not things you need to go to the ER for, particularly when you've been to a doctor who prescribed them and authorized them. They're not complex, but they're things that people are going to the ER for. People who come into us after the fact because they had to resort that way to care. And of course, that's more expensive. We've also had folks who get sicker and who were able to work some and are now completely unable to care for themselves because of getting sicker in this disruption. So I think that's a tremendous cost as well.
Okay, and then my last and final comment, Ms. Murphy, the reason why that the recipient of care gets a different notice than the provider of care is because often when government gets involved, the right hand does not know what the left hand is doing. So
I'm Catherine Blakemore, and that was...
Sorry.
That's okay, just so we know
Sorry,
who's who.
Blakemore.
That, it is, in this particular case, an example of the notices not lining up correctly, and that really isn't a very good outcome for anybody. It's going to result in hearings that are unnecessary because we haven't sorted out in a way who is in fact eligible for the service. So,
and a delay in delivery of services to the client.
And a delay in delivery if the person has to go to a hearing, absolutely.
Thank you for taking the time to answer those questions.
Any questions from any other members of the committee? Just in closing, Dr. Gilbert, just a quick question. I'd be interested in your response. We received letters from both Riverside County and San Bernardino County boards of supervisors, specifically with regard to the dual eligible pilot program. Clearly, folks with your experience is excellent, but they're expressing a variety of concerns about the pilot expanding and their, frankly, unwillingness to be involved. They say things like they're concerned about the state of California has not outlined a viable financial framework for the dual eligibles pilot. There's no clarity regarding the cost structure for IHSS under the pilot. It's also unclear as to whether counties would continue to be responsible for portions of IHSS costs. It's a list of issues. So in that, your plan in their counties, just are you willing to respond?
Absolutely. So interestingly, I'm a joint powers agency, so 4 of my 7 board members are county boards of supervisors, actually. So I had to get up in front of them and talk about this. The letters are slightly different. San Bernardino said, we don't want to be one of the first 4. Riverside said this is a letter of non-support, so they're slightly differently. And I know both of the people that wrote them. So their 2 key issues are IHSS, 17.85% is county match. They do not want their county dollars put at risk, I mean, to be really blunt. So they were concerned because the initial information that came out was not clear about the county match piece. Number 2 is they want to know what their role is going to be, their county social workers, in assessing the IHSS individuals. So those 2 things, and I've said very clearly, I said it at the previous hearing and this one, hopefully I'll say again, is those 2 have to be worked out. And our counties have said we need those understood. I'm saying I can't put you at risk. 4 of my bosses are County Board of Supervisors members. So the good news, Madam Chair, is that I talked directly with the 2 counties, with the 2 DPSS heads, and we're working together on it. But they clearly need those issues addressed. So they're not concerned about the overall financing of the duals. They're specifically concerned about their 17.85% match.
Yes, Mr. Monning.
And I don't mean to interrupt your line of questionings, but just on this specific point, and I know we're going to be discussing in-home support services as a component of this in later panels, but Dr. Gilbert, you raised what's, to me, an inherent conflict where you have a county being interested in protecting its budget, and if that results in not contributing to the in-home support service share, then the default may be for a patient who would benefit from that being in a higher cost institutionalized setting at somebody else's expense. Is that an accurate framing of the problem?
No, but, and I'm going to get myself in big trouble here, is that I think that the county match has to be controlled and defined for them. And anything else, if we want more services or if the individuals need to get paid more, that's on me. I am at risk for that. So if we go into a home and say this patient's really frail and needs more than the county social worker says, so they say 20 hours a week and we say 30, I have to pay for that additional 10 hours.
That'd be for the difference,
Right.
based on a different, that would make a predictable county commitment or contribution.
Exactly.
And the difference.
Is my risk.
Right. Thank you.
And I think if I might just add to that, it is how this becomes the Rubik's Cube of trying to figure out what is good policy, what is good, having, what does it mean to have good providers, and what does it mean around financing? And they're all interrelated. But we really should start with what is good healthcare policy and not have those decisions driven by financing models.
With that, we want to thank this panel for your participation. If I could see from the audience, just briefly kind of by you raising your hand, the number of people who fit in these two criteria. People who cannot stay to the end of the hearing, and it's not real predictable what time that will be, to offer public comment at the end, and or people who have a burning desire to focus your public comment on the panels we've heard thus far. Will those 10 people find your way to the line, stage left here of the hearing room? Yeah. I only saw about 10 people, so I will ask that others not add on. Again, burning desire to focus your public comment on the panels that I've already presented, as well as an airline flight or some other factor that will force you to leave before the hearing is over. So the rest of the people in the far left, if you could find seats either upstairs or in the downstairs area so I can get a real sense of who's in line and who's not. There are some people in the back of the hearing room. Would you please move to the right or find a seat? So I know that you're not in line. So will the gentleman at the back of the line in the glasses raise your hand? You are our last witness in public comment for this section. And you're in line. I got you. Thank you very much. Given the length of the line and the rest of our agenda, the gentleman, raise your hand. You're the last one in line. I see people adding onto the line, and he's the last one. So we'll need to ask you to Are there any individuals on this right wall who intend to participate in public comment at this period? Those of you in wheelchairs, I just want to make sure that we're clear who's testifying, who's not. Okay. We'll ask everyone to limit your comments to 2 minutes. And we thank you very much. First witness.
Thank you, Madam Chair and members. Michael Arnold, representing the California Dialysis Council, talking not about long-term care, but about shifting dual eligibles. ESRD patients or Medi-Cal, or dialysis patients experienced grave difficulties during the SPD transition. Those difficulties came in a lot of areas. We've given the committee case examples. I'll talk about 3. First, people who were signed up with a transplant center who were undergoing perhaps desensitization programs. The transplant center they were signed up with did not have a contract with a new plan. They were forced to switch to a different transplant center and many times were delayed for long periods of time, sometimes having the potential to die before they get their transplant. Secondly, the area of patients with catheters, access for dialysis. That is an open area for infection. Those patients who had an appointment with a vascular surgeon to replace the catheter with a fistula, then found that that vascular surgeon did not have a contract. They had to go to a different vascular surgeon. They had to wait months. Meanwhile, the potential for infection showing up at the ER, inpatient hospitalization, etc.
10 seconds.
Lastly, many problems with non-emergency medical transportation for these patients. If you do the transition of dual eligibles, you must realize we have about 50,000 ESRD patients, only 5,000 of whom were in the SPD population. So you're going to have about 40,000 patients, 5,000 are private pay. You're going to have about 40,000 patients, so many times more problems than we had before. So please, if you do the transition, please exclude dialysis patients. Thank you very much.
Thank you.
Lastly, I'm so sorry. The exemption process simply doesn't work. It does not work.
Never did. Thank you very much. Next witness.
Thank you. I'm Francie Moeller, and I'm with ADA Compliance Services, and I'm going to hit a bunch of different subjects that related to both panels. The first thing I want to do is say you need to reconsider what low income is. I make $2,350 a month. Between my Social Security disability income and my ex-husband's pension. Out of that, I pay $1,400 a month for rent, and I pay $561.50 just for my medical coverage. That leaves me a whole $400 to live on a month. And people forget about those of us who fit in between, and we're not old enough to be considered. Yeah. And we've forgotten about those people who paid into the system but don't fit on either category. Secondarily,
thank you.
The county, I live in Sonoma County, which is a rural county, and the doctors are refusing new patients. My sister came to live with me, and we could not find a doctor who would accept her as a patient. And because we're a rural county, they pay less to the doctors also. So it is happening. It's happening every day, and I think you need to consider that. It's very, very bad. We could not find one doctor who would take her Medicare or her Medi-Cal. And it almost cost her life early on, and it did end up in the long run costing her life. She died from respiratory collapse. The next thing, I have been in managed care, and I've been under non-managed care. And with a union. My husband was a member of a union. My ex-husband was a member of a union for 40 years. And it was excellent. At the end, we could pick any doctor we wanted. We didn't have to have pre-approval for care. If a doctor that we needed wasn't covered, all we had to do was have the doctor we saw fill out a form. He could join the union. If I needed to have an open scan, I could get it done. It was very good. I also had Kaiser at one time, which is sometimes considered managed care. That was very bad.
10 seconds.
Okay. Finally, I want to tell you, I get calls from inmates where they're in jail and they're denied medication on a regular basis because the doctor at the jail says, oh, you have to dry out, you have this problem or that problem, and they will not be given the medication their doctors tell them they have to have. We have taken this issue on many, many times where they're being denied the medication they need, even if they're having headache problems that are severe. And you can't have doctors who think they know everything.
Thank you very much for your testimony. I appreciate it. Okay. Next witness, please. 2 minutes.
Hello, my name is Christoph Ahn. I'm 75 years old, and I qualify for both Medi-Cal and Medicare. I rely completely on California's safety net for low-income seniors and people with disabilities. I live in an assisted living facility in Glendale, California, and I consider myself very fortunate to participate in California's managed care program for people in assisted facilities. I know that a lot of people are afraid of the word managed care, but my experience of having a coordinated care team has been very positive. So I wanted to share it with you and to contemplate an expanding managed care to include more long-term service. I'm standing here alone right now, but if you could see the team of people who helped me, not just to survive, but to lead a healthy, fulfilling life, there would be a small crowd of people standing around me. I would introduce to you my primary care physician, my neurologist, my case manager, my therapist, podiatrist, vascular surgeons, and wound care team, and many, many more people. With Parkinson's, atherosclerosis, vein failure, and severe edema in my legs, osteoporosis, spinal stenosis, depression, and a history that includes episodes of Parkinson's-related dementia. Among other things, mine is a very complicated medical case. I take 17 medications a day, and staying healthy occupies a large share of my energy and attention.
15 seconds.
I simply cannot imagine how I would manage all this without my team, even though I'm a former nurse. And it's done right, and coordinated care is a win-win. I win because I stay healthy. Taxpayers win for the same reasons, hopefully. And I hope my experience helps you to make good decisions, and I thank you for your time.
Thank you very much for your testimony.
Thank you.
Much appreciated. I'm jealous because you weren't wearing glasses when you were reading that, and so I need your coordinated care people to help me out. Thank you very much. Next witness, please. 2 minutes.
Thank you. So am I, Chair Mitchell. Thank you for listening to my testimony. My name is Miwa Lee. I am the Development Director for the Korean Resource Center. We didn't realize we should have sent it ahead. I'll make this quick. I'm here to testify on behalf of our community who has some concerns about this transition to managed care. As you know, since Medicare benefits have already been cut, our seniors' vision care and hearing has also been dental care has been cut as well. Well, we're worried that this Medi-Cal transition to managed care is going to create greater harm. Chair Yamada and Dr. Samuelson and Ms. Murphy had already touched on this about the additional costs. This is an example that I wanted to talk about right now. The majority of our community members are limited English proficient, LEP, and find it difficult to navigate the U.S. health care system as it is. So imagine all the problems that you just heard, plus the language barrier on top of that. So, for example, when Medi-Cal was switched to managed care system last year, one of our seniors came to us in distress because she was not allowed to see her regular doctor. She did not understand what managed care was, that she was supposed to choose a primary care provider. Although some of the forms were in Korean, the vast majority of them were not. She thought it was junk mail. She threw it away. She got into trouble. So when the system automatically assigned her a primary care physician, they, of course, chose a doctor who was too far away. She's a senior. She relies on public transportation, and she's physically not completely able, so it was difficult. Plus, he didn't speak Korean, didn't have anybody to translate. So as a result, she skipped her regular doctor appointments, her medication. She got worse. She would bounce into emergency care, got emergency care, and which costs a lot more, obviously, and it just kept happening repeatedly. I'm trying not to go past 2 minutes. So switching to Medi-Cal to Medicare managed care was supposed to save a lot of money, but instead, health care for this particular senior ended up costing us, the state, and all of us many times more, and put her through a great deal of stress and worry that contributed to even more health problems. So with some variation, this story is repeated many times by our clients in just our organization alone. We serve Koreatown, but we know that there's a lot more out there that don't even come to us. So it's clear to us, at least at KRC, that at best managed care can drastically limit access to much needed health care. At worst, it can be life-threatening for our LEP seniors.
10 seconds.
If Medicare is destined to follow suit and become Medicare is destined to follow suit and become managed care, I urge you to consider the needs of our community members who cannot be here today and who are helpless to speak for themselves. Please consider these 4 things. Ensure a clear process for complaints should anyone experience problems. Require all documents and forms to be translated into primary languages of the community being served. Provide funding for language-appropriate community education assistance from local organizations like us, KRC, to help seniors and LEP community members get through the transition process without losing critical care, and requires sufficient number of multilingual primary care doctors for each community being served.
Thank you very much for your testimony. Next witness.
안녕하세요. 저는 LA의 노인 아파트에 살고 있는 72살의 최병년입니다. 저는 미국에서 오랫동안 봉제 일을 하려 하였고 말이 안 통하는 이곳에서 일을 하고 살 수 있다는 것에 감사하고 이렇게 열심히 일하면 나이가 들어서 내가 낸 세금이 나를 살릴 수 있으리라 기대했습니다. 저는 메디컬 혜택을 받고 있고 몇 년 갑상선 수술을 받았습니다. 그런데 얼마 전 암이 재발되었고 이미 여러 군데 암이 퍼져 있어서 수술은 하지 못하고 의사의 치료와 약으로 암을 다스리고 있는 상태입니다. 저는 영어를 하지 못하기 때문에 한국말을 하는 의사 선생님을 찾았고 만약에 외국인 의사를 보게 될 때는 제가 통역을 구해서 병원에 다녔습니다. SSI를 받고 있는 저로서는 이것조차도 상당한 부담이 됩니다. 올해 주지사의 제안대로 메디컬 매니지드 케어 시스템으로 바뀐다면 저는 어떻게 해야 될지 모르겠습니다. 한국인 의사가 그리 많지 않은 상황에서 벌써 오랫동안 저를 치료한 의사를 만나지 못할 수도 있고 새로운 의사가 한국말을 할 수 있는지 내 암을 잘 치료할 수 있는지 급작스러운 일이 발생했을 때 곧바로 병원으로 갈 수 있을지 걱정됩니다. 오랫동안 저는 메디컬 삭감이 있을 때마다 시간이 지나면 괜찮겠지, 정부에서 나와 같은 힘없는 노인들을 구해주겠지 생각하면 믿고 기다렸습니다. 삭감보다는 세금으로 이러한 프로그램들을 보호해 주세요. 그런데 올해 예감만을 보니 저와 같이 삭감한 병을 가지고 있는 사람들을 또 다시 두려움을 느끼게 됩니다. 나이도 들고 재정도 넉넉하지 않은 상태에서 암이라는 큰 병을 가지고 있는 저와 같은 사람이 안심하고 병원에 갈 수 있도록 도와주십시오. 감사합니다.
감사합니다.
I'll try it in English. Hello, my name is Pyongyun Che. I am 72 years old and live in a low-cost senior apartment in Los Angeles. I worked for many years at a sewing factory. I was grateful to just have the chance to work in this country, even though I could not speak English. I expected to have a comfortable senior life from all the taxes I paid earlier. I'm a Medicare beneficiary. I had a thyroid surgery a few years ago, but my thyroid cancer came back and has spread to several areas. A second surgery is not possible, so I am receiving other treatment. Because I cannot speak English, I always have to look for a Korean doctor, and when it's not available, I have to find an interpreter. As an SSSI beneficiary, this is very burdensome for me. If Medicare shifts to a managed care system, as proposed by the governor, I don't know what I will do. It is very hard to find Korean-speaking doctors as it is. If we change to managed care, I worry that I won't be able to keep my doctor who knows me and can treat me. I worry that a new doctor won't be able to talk to me. I worry whether he will be able to give me adequate treatment for my illness. I worry in case of emergency if I will be able to find a proper facility that can treat cancer. For a long time now, with each budget cut that reduces more medical coverage, I hoped things would get better in time, and you would try to get more money so there are less cuts. Please try not to forget vulnerable seniors like me, but seriously ill people like me get scared as we see even more budget cuts being proposed this year. Please support seniors like me who have no resources and have a serious illness like cancer. We just want to be able to go to the hospital without too much worry. Thank you.
Thank you very much. Next witness, 2 minutes, please.
안녕하세요. 저는 LA 노인 아파트에 살고 있는 77세의 윤옥숙입니다. 저는 아이들이 어렸을 때 미국에서 공부를 하면 잘 살게 되리라는 아메리칸 드림을 희망을 갖고 미국으로 건너와 말도 통하지 않는 곳에서 세탁소를 아침 일찍부터 밤늦게까지 운영하면서 30여 년 가까이 세월을 미국에서 살았습니다. 그때는 열심히 일만 하면 노후 보장은 정부에서 알아서 주리라 믿었기 때문에 고된 노동에도 힘들 줄 모르고 아이들도 잘 자라 이 나라의 일꾼으로 열심히 사회에 봉사하고 있습니다. 그러나 저는 나이가 들어가며 노된 노동의 후유증인지 콜레스테롤 수치도 높고 디스크도 생겨서 때로는 걷기조차 많이 힘듭니다. 제 남편은 1977년에 중풍으로 왼쪽 뇌 손상을 입어 언어장애가 심하고 오른발이 마비가 되어서 걸을 수가 없었습니다. 그러나 꾸준히 병원 치료를 받고 양로보건센터에서 운동도 하고 물리치료도 받으면서 이제는 지팡이를 들고 걸을 수가 있는 정도 되었습니다. 그러나 혼자 밥을 먹는다든가 몸을 씻는다든가 하는 것은 힘이 들어서 간병인의 도움이 필요하나 나라의 살림이 어려우니 저라도 보탬이 되고자 간병인의 도움을 마다하고 제가 움직일 수 있는 동안은 남편을 도와드리고 있습니다. 그러나 최근에 양로보건센터가 문을 닫을 수도 있고 또 메디칼이 매니지드 케어 시스템으로 바뀌면 남편이나 저가 병원을 예전처럼 다닐 수 없는 것 같아 걱정입니다. 우리같이 나이가 들고 몸이 아파 병원의 치료나 물리치료에 의지하는 사람은 이제 어떻게 해야 될까요? 나이가 들어 저도 열심히 일을 해서 이 나라의 경제에 조금이라도 풍성해지도록 도와드렸습니다. 이제 우리 노인들이 두려움 없이 병원이라도 다닐 수 있도록 도와주세요. 감사합니다.
Hello, I'm Ok Suk Yoon. I am 77 years old and live at a senior apartment in Los Angeles. I came to America when my children were very young in search of the American dream. With an education here, I hope that my children would have a much better life. Unable to speak English, I worked long hours in a coin laundry from very early to late at night for nearly 30 years. Back then, I believed that if I worked hard and paid my taxes, I could rely on the government in my old age. Although it was exhausting, I didn't mind working hard when I saw my children grow up to become hard-working Americans who serve their community. As I became older, I guess the years of excessive labor must have damaged my health. I have high cholesterol and a disc problem that makes walking very difficult. In 1997, my husband had a stroke and suffered brain damage. He has a language difficulty and his right leg is paralyzed. After receiving physical therapy from adult daycare center, he is now able to walk with a cane, but he still cannot cook or wash himself without the help of a caregiver. I heard California is going through a budget crisis, so I did not want to spend government money. I have now applied to in-home supportive services. I will take care of my husband for as long as I am physically able. Now, because of managed care, ADHS may close, and my husband and I cannot see our regular doctor either. For seniors like us who have to rely on the doctors, treatment, therapy, and medicine, what are we supposed to do? Do we have to live in a great pain simply because we are too old to work and cannot pay more income tax? When we were young, we worked hard and helped to build this country's economy. Please help us seniors so we can get at least go to the doctors without fear or worry. Thank you.
Thank you very much. As the next witness comes forward, 3 people joined on the line. After we cut it off, I invite you to take your seats, and we look forward to hearing your testimony at the second public comment section. And that's everyone behind the gentleman in the burgundy sweater. Everyone behind the gentleman in the burgundy sweater. If the surgeons could provide some assistance, we invite you to provide public comment in the second panel. Thank you very much. Next witness.
Hello. My name is Michael Patterson. I'm from Tuolumne County. It's a very rural county. And I'm an in-home supportive services care provider, but I'm also a dual beneficiary. I'm trying to return to the workforce, be a contributing citizen. But in our county, there's no coordination whatsoever, and all the services that I've ever received, I have found out from other patients or other beneficiaries. When you talk to the people in the social services building, they don't recommend any different services, or at least that's been my experience. But in taking care of my recipient, I wish there was more training available to me so that I didn't have to take her to the emergency room all the time, just because I know something's wrong, but I don't know exactly what's wrong. And so I have to take her quite often to the emergency room. She can't just go into doctor's appointments all the time because of her health level. We have a great doctor. It comes to the home, but it's not whenever she needs it, it's once a month. So I would like to see some coordination and some integration of services, but I would also like to see that the control was in the hands of the consumer. Thank you.
Thank you very much. Appreciate your testimony.
My name's Heather, and I just had heart surgery last month, and my tests were having to be duplicated all the time. Every set of doctors is having to rerun the tests, and it's taking so long, and I have a fatal disease, and I don't want to die any sooner than I have. So I implore you guys to please look and begin to have some coordinated care, because I don't want to fall through the cracks.
Thank you.
Thank you very much. Appreciate your testimony.
Hello, thank you for hearing me today. My name is Cassandra Carter. I'm from Shasta County, Redding, California. I'm a resident of 15 years and a care provider for the last 6 years. I have two clients. One is wheelchair bound, and the reason I'm here today is to express to you better training as a provider. With better training, the higher the quality of care I can provide for my client. And this is a job I love, taking care of people. Being able to attend the doctor's office is very important with my client. As part of the client's care team, that's a very important step. I just have to say that again, because when my client is in pain and can't concentrate on what's going on, and the doctor is shouting instructions to them, they're not understanding that. They just want to get home quickly. So being trained in that area for me will allow me to help that client with medications, defibrillators, whatever the need is, if the client permits. And I just really want to express that training for providers, and I want to thank you guys for letting us have the opportunity to speak to you. I know you're very busy, so thank you, and God bless you all. Have a great day.
Thank you very much. 2 minutes, please. Next witness.
Madam Chair, committee members, my name is Anwar Zwahed from Partners in Care Foundation. I'm here representing approximately 900 MSSP beneficiaries in the Los Angeles and Kern County area. Just several points about MSSP. These MSSP services are a great value. These services need to be protected. These services are complex and detailed. MSSP is like a mini HMO. It includes a thorough assessment and care planning process that focuses in improving premium health and human services that allow members to continue community living and, by default, reducing nursing and hospitalization. MSSP is the only program that provides this level of detailed professional service that keeps the frailest members in the community, lowering overall costs to the state. I have an issue, I feel like this is going a little bit too quickly in this integration process. A more careful and thoughtful implementation process will ensure MSSP core services are retained and even expanded. Thank you.
Thank you very much. Next witness, 2 minutes, please.
Madam Chairs, members, this is Al Hernandez Santana, representing the California State Rural Health Association. We simply want to strongly underscore the lack of access in rural areas, and joining one of the comments